Hi, my name is Isan Valgefi and I'm a bioengineer. The area of my expertise has always been vision, imaging of the eye, and blindness. The reason I've been interested in vision and blindness is because of um, my personal passion and my personal story. My father was blind when he was 4 years old. And the reason he went blind at that age was because of a preventable disease that if it was diagnosed, it could be treated. And the fact that at the time they couldn't treat my father and they couldn't diagnose his pathology and disease, it's been with me for my entire life. And that I made it my mission to create technologies that we can actually avoid preventable blindness. 2 years ago, we started Toku Eyes, which is a startup company out of the University of Auckland. And with my clinician colleagues, we started looking at diabetic retinopathy. Diabetic retinopathy is the leading cause of blindness in the working adults. And it's, as the name suggests, is a consequence of having diabetes. People that have diabetes will eventually have diabetic retinopathy. It's just a matter of time. In some people, the condition happens earlier, and in some people later. So the nature of the uncertainty about the disease means that every diabetic person has to be screened constantly and routinely so we can identify the people that are just about to develop retinopathy and start the treatment. So we started developing an artificial intelligence that we called Thea. This is a unique artificial intelligence that we developed in New Zealand based on New Zealand data and standards. And our motto was to leave no one behind. Essentially, we want to offer this service to anybody all across the country and make sure that the diagnosis of diabetic retinopathy by our AI is as accurate as a clinician. Currently, diabetic screening involves a lot of steps, and several clinicians are involved in the pathway. The person with diabetes has to turn up at a hospital and get photographed, and that photograph is then adjudicated or diagnosed by several clinicians along a sort of certain pathway. That takes a lot of time, and also it's very expensive. So a patient has to go home and wait for the results. The results often are only generated 8 weeks after the image is taken. During that time, the patient has to wait for the results to come, and the disease is slowly progressing. So it's a very stressful and sometimes risky period of time for the patient. Also, when the patient travels to the hospital, they have to essentially dedicate most of their day to turn up at a hospital and go through the system. So it's also inconvenient. A lot of people that actually don't show up for their appointments are young professionals, people that are just too busy with life, and they just miss an appointment in a hospital setting. So as you can see, this system, although it's a public system and we are fortunate to have it, it's not efficient. And we believe that artificial intelligence can improve this national screening service much more. So with the help from clinicians from counties Manukau and Auckland DHB, we essentially got a whole lot of data from those two DHBs. And the data is unique to New Zealand. As you can see, the demographics of patients that we have gathered the data is representative of New Zealand, because a major problem with developing artificial intelligence is that if the artificial intelligence is trained using a certain ethnicity but not others, it can have biases in it. So by using the data that's representative of New Zealand for training and testing our artificial intelligence, we made sure that this particular artificial intelligence is not biased. We also set out to automate the entire system. Essentially, if when you turn to a hospital and an image of your eye is being taken, the clinician, the first decision is to understand if this is a good image, good for diagnosis, or should it be repeated? These are some of the examples of poor images. We made our artificial intelligence such that the artificial intelligence, the first step is it will tell the clinician if it's a good image or not. And we can do that in less than 2 seconds. So the clinician doesn't even have to bother himself or herself about the quality of the image. We can just process with their routine. There are lots of numbers on this slide, and I do apologize for that, but probably the 2 numbers that you really want to focus on is the sensitivity and negative predictive value, or NPV. The sensitivity essentially tells you how good the artificial intelligence is in detecting the disease. And as you can see, we are about 95% accurate in detecting diabetic retinopathy. NPV, or negative predictive value, tells you that if we decide that a patient is healthy, so they do not have diabetic retinopathy, how certain we are. And as you can see, we are more than 99% sure that when we send somebody home because they're healthy, the person is actually healthy. These numbers are pretty much comparable to what you would expect from a very sophisticated clinical service here in New Zealand or anywhere in the Western world. One of the problems with artificial intelligence is that often it's created as a black box. So the clinician doesn't get to see what happened inside that black box and how did AI come up with the decision at the end. And we didn't want to do that. So essentially, we made our artificial intelligence such that every time a decision is made, there is a map created that we call an attention map. An attention map essentially highlights the areas that the artificial intelligence is noted. So now the clinician has the option to look at the attention map and understand if the decision made by AI is based on correct areas inside the image, based on their clinical knowledge, or not. So we always wanted to be transparent about what is our artificial intelligence uses as the basis of the diagnosis. So as you can see, what we have done with this artificial intelligence, we have tried to collapse the screening program from a very long and very clinically involved process into a much simpler one. So what we are proposing now and what we are testing is that you don't have to turn up to a particular hospital, which is run by DHB. You just can go to any optometrist and at your own time. And the optometrist can capture the retinal photo or the fundus photo. The artificial intelligence will then do the diagnosis, and on the spot, right there, in the optometry clinic, you will know if you have a healthy eye or you need further attention. So suddenly, instead of waiting for 8 weeks to receive the results, the patient can only the patient will receive the results instantly. Also, instead of having 4 or 5 clinicians involved in that process, for 75% of people that are healthy, there's only one clinician, who's the optometrist, involved in the process. The other set of people, maybe about 25% or less than that, those are the people that the AI will flag as people that needs to be seen by another clinician who's going to be the ophthalmologist, and only those people, that percentage of people, will actually need to go to the hospital. So now suddenly we have reduced the number of people that are actually needed to go to the hospital. So we hope that by developing this artificial intelligence, we will make this screening, the diabetic screening program, standardized, much more affordable for the government, and available all across the country. Because right now, this system is pretty much clinic-centric, and you have to go to a particular clinic. So we believe that we have the ability to democratize the screening service, which means it's available in any optometry clinic that you attend at your own time. And we hope that using our artificial intelligence, we can save the vision of the patients that otherwise would have suffered. So this is again my story. I do believe that the technology should be able to save people from preventable blindness. And we have all the tools necessary to achieve that aim. We have been doing our research for the past 2 years. We have been lucky that we could have the clinical backing and support of all the clinicians that we have been interacting with, and I'm very grateful for that. We have also been lucky to attract enough funding that we can do this research. It's been an amazing journey. I just wanted to probably show you one thing, and this is a tactile watch. It's the same watch that my father wears, and this is a watch for the blind. And I wear this every day as a reminder of my personal mission to work towards a future that preventable blindness is actually prevented, and nobody goes blind or lose their vision simply because they didn't have access to technology. Thank you.